My name's Dave Griffith. I'm professor of medicine at University of Texas Health Science Center at Tyler, a respiratory physician, and someone who's been interested in non-tuberculous mycobacteria for quite some time. I'm here with my colleague and good friend, Kevin Winthrop.
I'm from the Infectious Disease Division and School of Public Health at Oregon Health Science University in Portland, Oregon. I too have been interested in NTM for a long time, not quite as long as Dave. The guru on therapy sits here. So tell me, what do you worry about when you treat these people? What drugs do you want to maintain activity, resistance? These are important topics, and we run into these problems in clinic all the time.
It's extraordinarily important, and it's really hard to convince people exactly how important it is. People want this disease to be tuberculosis, and it's just not. And it boils down to the fact that we basically have two drugs where we can predict treatment response based on the in vitro susceptibilities of those two drugs, and that's the macrolides and amikacin.
So azithromycin, clarithromycin, the macrolides, and yeah, amikacin. Those are important drugs.
Absolutely. And the corollary to that is when patients become resistant to those medications, they fail therapy. And there are no other drugs where you can make that association. And basically it behooves the practicing physician to protect those two agents.
So macrolide resistance it's pretty rare, let's face it, and it doesn't really occur naturally, does it? I've never
Not
seen.
at all.
Yeah,
No,
that's right.
no.
So it really has to occur in someone who's had antibiotic pressure with the macrolide for, I don't know, 2 weeks, 2 months, 2 years. How long?
Well, it probably takes months, I would say. Now, in the original study that we did using macrolide monotherapy, which unfortunately proved this point, it could occur actually within a month, within about 4 weeks, but more often after a couple of months.
Let's talk about macrolide monotherapy. It happens. I can't believe how often it happens. So, you've done studies, we've done studies. It happens 15, 20% of the people with MAC seem to be put on macrolide monotherapy for some time period. There might be reasons why that's happening, intolerance to other therapies, things like that, but it shouldn't happen.
Kevin, how loudly can we beat that drum? I have no clue. You and I have both been at this for a decade or two, and as you say, it still happens. I consider it every bit as egregious as a physician treating a tuberculosis patient with a single drug. It just should not happen.
So how do you prevent, what drugs do we need to use to prevent it from happening?
Well, it's very clear the one essential drug is ethambutol.
Sure.
And the MICs for MAC, for ethambutol, are very high. Ethambutol is not an effective drug for killing MAC, but it has a role in augmenting or facilitating killing by the macrolide. There is no other drug where we are as confident that pair will prevent the emergence of macrolide resistance.
I was telling someone the other day, they said, hey, so what's the key to this multi-drug therapy? The key is protecting the macrolide.
Absolutely.
We use these other drugs to protect the macrolide because it's our most active drug.
Correct.
Although let's talk about amikacin, talk about active.
Absolutely. Amikacin is the other drug where we know there is an association between the MIC, treatment success, and treatment failure, which again behooves us to take care of the amikacin, to protect the amikacin against the emergence of resistance. And one thing that worries me is that people use inhaled generic amikacin in ways that exposes it to the emergence of resistance.
Yeah, well, you showed that in your data. I think you were the first people that showed it. You can acquire mutational resistance to amikacin with the use of regimens that don't protect the amikacin, so to speak.
Absolutely. Yeah. I guess what worries me is this requires a couple of levels of knowledge that most physicians either don't have time or interest to have. Yeah. People want, again, they want this disease to be tuberculosis. They want to be able to just plug in the drugs, and you can't do that with MAC. You have to know something about how they behave in the host, and which is unfortunately different than how they may behave in.
And that's why we have guidelines, right?
Right, which no one
nobody
follows.
Yeah. Well, at least the smart people follow them, right? No, we do have guidelines, and Dave and I were both part of that effort.
Absolutely.
That was years ago, and there's a new effort at hand now with various medical societies, American Thoracic Society and the IDSA, et cetera, to produce new guidelines. Those are coming soon.
Right.
But I think that's the important thing, is how do you use these drugs, and what combinations do you use them, and how do you deal with the intolerances and the problems that you encounter? And you might have to drop a drug for a time. It gets complicated. It isn't easy to do.
It is not easy. As they say, if it was easy, anybody could do it. I would just like to say, the guidelines are clear, and they're not perfect. Absolutely, there are limitations to those guidelines, multiple limitations. But if you follow those guidelines, you're not likely to make things worse.
Yeah, you're not likely to do your patient a disservice, which is what we're trying to do.
They may not get better, but you are at least not going to make them untreatable.
So I'll wrap this up by saying, do we have an unmet need? We do.
Absolutely, we have.
We don't have many drugs to work with. If you guys have a drug out there that might work, please call Dave.
Well,
And let's evaluate it, because we do need new therapies.
I do think that the new inhaled liposomal amikation preparation is the brightest light we've seen in this night sky in a long time. I'm just curious how you feel about it.
Yeah, and I think there's a variety of other compounds in the pipeline that will also likely prove to be useful. So we need more studies. We need more time, but I do think there's a bright future on the horizon for our patients.
I agree. I am more optimistic now than I have been ever in the past.
Good to hear. We'll close there. I'm Kevin Winthrop.
And I'm Dave Griffith. Thank you.
Thanks.